next are the ectopic pulsations which you are going to get. They are the suprasternal pulsation as well as sternoclavicular pulsation which you are going to like appreciate here. So what is there is like, for example, if this is your manubrium and this is your sternum which is going like this. So these are the suprasternal pulsations. Suprasternal pulsations. It is due to your thyroid edema artery which is coming here. That may be the cause of your pulsation, or it could be arch of aorta which is running like this. Okay. That can be a part of your aneurysm which has formed, it could be there, or due to sternoclavicular. So here is your clavicles which are going like this. So there will be aortic dissection which is involving splitting of the aorta, that can also cause, or aneurysm of aorta, or like aortic regurgitation. What happens is there is a large bounding pulse going and returning, going and regurgitating. So that can also cause an impulse here, or sometimes there is a right-sided aortic arch which has been formed like congenital abnormality. That side also you can get a right-sided here pulsations. Other than that, you are having your subclavian arteries and all are there. That can also, like for example, this is your aortic arch which you have, and here you have subclavian arteries and all. So even those are also running behind your clavicles only. So even aneurysms of those can also cause, but not like the first answer to be given. So here these can also cause your supra or infraclavicular pulsations. So right-sided second intraclavic as aneurysm of the ascending aorta, or in case of chronic aortic regurgitation. So what is there is like in case of what happens is, for example, if this is your cardia, then you are having aorta which is going like this, and you are having aortic valve here. So this is your right second intercostal space. So this is your second rib and third rib, and you are having the intercostal space here. So here what has happens is aneurysm of the ascending aorta has occurred like this, or there could be chronic aortic regurgitation which is having an impulse here at the level of valve. So that can also cause second intercostal space pulsations. So next is the left-sided second intercostal space and third intercostal space pulsations. So it is due to pulmonary hypertension. See, as like we have here, so we have got a pulmonary artery which is also arising like this here. So pulmonary artery which is also arising. So it is also going to give, but sternum is on the it is on the midline here. So it is on the left side here. So left-sided we are going to have pulmonary arterial hypertension, and as I said, increased pulmonary blood flow which is occurring as in case of PDA and ASD. So in case of ASD, what happens is, even though there is a atria like low pressure chambers, so there is always a flowing of the blood from left to right. So invariably again it will have right sided to increased pulmonary flow will be there. That can cause your PDA like and ASD. In case of PDA, what happens is, if this is your pulmonary artery which is like it is there, and you are going to have aorta here, and we are having an abnormal connection here. So this is going to cause increased flow here, and we are going to get a developer. Later we are going to develop here pulmonary hypertension. So this pulmonary hypertension can cause your loud P2 and pulsations in the level of left second intercostal space. And idiopathic like pulmonary artery dilatation, like in case of aortic aneurysms, pulmonary artery dilatation can also lead to a prominent pulsation in the left-sided second intercostal space. And fever, hyperdynamic circulation, not as prominent as aortic, but it can cause like second intercostal space pulsations. Then left parasternal pulsations. So left-sided parasternal area is actually, for example, this is the sternum. This left-sided parasternal area is actually occupied by the right-sided cardiac areas. Okay. So right-sided cardiac events which are occurring early in the childhood will cause parasternal heave. So for example, in case of tricuspid regurgitation, ASD, VSD. So in case of tricuspid regurgitation, there is a regurgitation of blood from back, like from the ventricle to atria and again back. So there is a volume overload like condition here. In case of ASD and VSD, as I said, if this is a ASD and this is a VSD here, always there is a excess of blood flow like this. So this is a volume overloaded condition which is occurring here. So this is going to cause a right-sided hypertrophy as well as dilatation. And in case of RVH, pressure overload conditions we have. So pressure overload, like for example, if this is the pulmonary artery which is going out like this, and we are having here pulmonary stenosis, pulmonary artery hypertension, which is causing due to secondary to like embolism which has landed up here, or it is due to the lung pathologies which are here, which are lungs. Due to lung pathologies, there is development of pulmonary artery hypertension. That is also going to cause pressure overload conditions. Again, concentric like you are going to have hypertrophy on the right ventricle, and then you are going to have later on stage you are going to have dilatation. So that can also cause left-sided parasternal pulsations. As normally, children and teen adults can have a physiological left-sided parasternal pulsation can be visualized. So in case of what happens is moderate to severe mitral regurgitation, what happens is the jet which is formed from the left ventricle, okay? Like as I said that time in diagram, so this is the LA which is there, and this is the apex which has been formed, like this is your cardia, this is your RV, this RV comes here. So this will be your like RA here, sorry. RA here, RV here, and this will be the LV apex which is being formed here. So what happens in case of mitral regurgitation? The jet of blood which is going like back into the left atrium, this will be actually LA will be situated posteriorly. So it is a posteriorly located structure. So that is going to cause your pushing up of the left atrium and right atrium and right ventricle. So from the backside, it is going to push your right-sided chambers, and that is going to cause your left-sided parasternal impulses. Okay. Then coming to next is epigastric pulsation. For example, if we take like this is the diaphragm which is there, and this is the liver which we have here, and this is the abdominal wall, and this is the epigastric xiphisternum we have here, and then we have the two lungs which are going here, and this is the cardia which we have here. So if you put a pulp of the finger like this, okay, this is your thumb, and if you put a finger like this, what are the impulses you are going to feel? Okay, if from the like on the radial border, you are going to feel the hepatic impulses on this side. Okay, if the cardiac enlargement is there, then it is going to come like cardia is going to shift down like this, and you're going to feel it as the tip of the finger. Okay, and if you're looking from the side angle, okay, if this is your pulp of the finger and this is your nail, like something like your finger, the pulp of the finger which is there, you are going to feel the aorta which is down inside. So it is from deep inside, you are going to feel the aortic pulsation. So three fingers, like you're going to put like a pulp of the finger, or you can put even thumb like this. So if you're putting a thumb, so then you're going to have on one side, you're going to feel the hepatic, on the tip, you're going to feel the cardiac, and here on the pulp of the finger, you're going to feel the aortic pulsations. So this is how you're going to feel the epigastric pulsations. So any other ectopic pulsations which you can feel is, so ectopic LA and LV impulses can be visualized, like sometimes you can visualize, like even in case of mitral regurgitation, what happens is anterior mitral deflect abnormalities will have jet of the blood which is going posteriorly into the axilla. So at that time you can have enlarged LV can, or like LA and LV both can cause impact over the axilla, and that can have prominent impulse which are you can visualize in the axillary area, you can look it for. And in case of beneath the clavicle, you are having a PDA impulse can be prominently visualized on the left side. Palpation, we have only few slides. So examination of the chest, like you have done everything, and as the palpation goes, look for the raised temperature and tenderness anywhere in the chest. So it can cause, like indicate your underlying inflammatory pathologies, or your fracture or costochondritis, or even it could be pericarditis or myocarditis, whatever is there, the local rise of temperature and any tenderness you are going to look for. Then you are going to look for cardiovascular specific findings, like you are going to look for thrills and rubs and murmurs, and you are also going to look for ectopic sounds like tumor plops are there, and we are having a pericardial knock we have. So those are the extra conditions we are going to palpate. So cardiovasculars, like we are going to palpate for the heart sounds like S1, S2 we are going to palpate. Then you are going to palpate for murmurs. Then you are going to palpate for the rubs, like pleural and pericardial rubs if any things are there. Then you are going to fall like ectopic, like or like other adventitious we can tell, not ectopic, other sounds we are going to, like you have got a tumor plop is there, then pericardial knock is there, then we have got a metallic artificial valves are there, they can also cause the sounds. So these are all the things we are going to metallic valve sounds we are going to palpate. And other like abnormal heart sounds are there, like they are usually not like prominent. S3, S4 can also be palpated sometimes. Okay, so we'll go now regarding the palpation of individual heart sounds. So as I said, tenderness, it is like teeth syndrome, pericarditis and myocarditis, like raised temperature and tenderness you are going to see. So as I said, this is the method of how we are going to palpate for the apical impulse. You can visualize here, he has kept one cardiac like carotid, he is also palpating, and is also palpating apex here. Okay, so both you can do it. So as I said, only tip you are going to use. So this is the direct method which you are followed in case of medicine books, they directly give. There is no method like this and then this, it is not there. Directly you are going to put the tip of the fingers and search for apical impulse. So As I said, this is the most common diagram and everywhere it is given. Here you are going to give for a localized pulsations, like you are having apical impulse you have, then you have S3, S4 and all you are going to do, and all the thrills you are going to palpate from here, and all the heaves you are going to palpate from heel of the hand. So even you are going to palpate like loud loud P2 and all you are going to put from tip of the finger only. So cardiac like apex palpation is like you're going to see it is normal, double or triple or shifted and all those things, and you're going to characterize the apical impulse like whether it's a heaving type of apical impulse or hyperdynamic type of apical impulse. As I said, this is one more diagram showing patient like palpation of apical impulse in the left lateral position. You can slightly make him to left lateral position and you can even palpate, and he has given like examination in this position reveals impulses not readily detected when patient is supine. Okay, so you can palpate here. Location and duration of apical impulse are frequently altered. See here. So this also statement he gives. So even when you are changing the position, so alteration of apical impulse can occur. So like for example, which will not be palpable in supine position may suddenly become palpable on one of the intercostal spaces at mid or like medial or lateral to mid clavicular line in the left lateral position. So you are going to just turn the patient and you are going to palpate for apical impulse. Then this is the area method is showing for applying the pressure over the sternal border, okay, left lateral border, and for the heel of the finger he is like heel of the hand he is using. So this area he is going to use, and he is going to obliterate and try for looking for any of the parasternal heave which are occurring there. So he is going to use the heel of the hand. Okay. Then types of apical impulse, we have absent or feeble. We discussed the condition. Tapping apical impulse is like it is seen usually in S1, and hyperdynamic and heaving we'll discuss. I think there are slides next. This is the area like he has found out there is an apical impulse which is there here at one intercostal space particularly. Okay, like how yesterday we saw in JVB they had put a sticker over the neck, and then over that they have put a stick like that. He is going to put here and he is going to look for the amplitude or exertion, how much it is up and down it is moving, and also how much time it is taking. For example, if this is a time graph which is there like this, whether the apical impulse is coming like this or apical impulse is going like this. So it is a time duration also you can like find out with the amplification of the apical impulse, which you can do it bedside. So tapping apical impulse is characteristic of MS, and it can be sometimes normal also in like normal heart sound also, and it is just it comes and touches the heart, like touches the palpating finger and then it goes down. That is a tapping apical impulse. So like hyperdynamic or hyperkinetic apical impulse, this is due to volume overloads states. So it is due to hyperdynamic or hyperkinetic impulses. So amplitude and duration of the apical impulse both are increased. So if you take a graph like this, so both will be increased. So this time is also increased and amplitude also increased, but it is ill sustained, like it is only for less than 50% of the systole. Okay, and we have got multiple causes here, so we'll discuss it afterwards. So heaving apical impulses, it increases in duration and amplitude, and it is for more than 50% of the systole. So it will be like more of a, it lifts the hand. So it will be more of a pressure overload conditions. So this is due to pressure overload conditions. So whereas this one is due to your hyperdynamic is due to volume overload conditions. So we have got here list, I think. No, they have not mentioned, I'll tell you. So I think they have not given even about the differences. So we will just look here. So we have got a hyperdynamic apical impulse. We have got a heaving type of apical impulse. Okay. So here what will be there? It will be more than one intercostal space. It will be like it will be less than or equal to one intercostal space. It will be. This is first one. And this is second one is due to volume overload state, and this is due to pressure overload states. And this will be less than 50% of systole, and then this will be more than 50% of the systole, and there will be prominent lift is absent here. Prominent lift will be absent, and there will be sustained lift will be present here. Sustained lift will be present in case of heaving, and it is due to AR, MR, VSD, ASD, like this volume overload conditions, and this is due to aortic stenosis, coarctation of aorta, then systemic hypertension. All these things are going to cause a heaving type of apical impulse. You should know 5 at least differences between both of them. They are going to ask. See, simplest thing, like not just for exam purpose, you are going to know. As I said previously only, I'll tell you by the end of this why we have to remember these differences and all. I'll tell it together only. Okay. Then regarding hyperdynamic and heaving type of apical impulse, then we have method of palpation. As I said, you're going to use the heel of the hand for parasternal heave. Then we are having palpable sounds. As I said, we have got S3, S4, knocks we have, and I don't think like it is like too much for you people to remember. Just if you tell like answer as S3, S4 and all, they don't expect from you people regarding what are the conditions where you want to tell like and all those things. So S3 is usually due to in case of volume overload conditions, it will be usually see like in case of volume overload conditions, you're going to get it like pregnancy, anemia with hyperdynamic circulations are there, or in case of acute heart failure where there is a difficulty in pumping out of the volume, you can get it. Anemia and failures, you can get it. In case of S4, it is due to stiff ventricles which are there where the atria is working fast and it is working hard to push the blood. So in case of restrictive cardiomyopathies and all, you can get a prominent S4. So aging is also normal phenomena where you can get like S4 can be a part of normal aging also. And in case of young people also, you can get young and pregnancy also, you can get normal S3 also. So I want you people to remember causes of S3, S4 are physiological causes. You have to remember like at least 2 causes, and pathological 2 causes. If you remember, it's more than enough for you. So you have to just try to answer them. What are the causes of S3 and S4? Then palpable high frequency sounds at apex. So these are the low frequency sound. So as I said, high frequency at the apex, we have S1 which is louder and it is palpable at the apex, and it is the opening snap. So what happens is this is the atria, these are the 2 valves which you have, and this is the ventricle. So atria, ventricle. So in case of stiff valves are there, the opening up of the valves during the ventricular relaxation and atrial contraction, like it opens during the end of the atrial systole, you can hear a prominent sound. You can even auscultate and you can even palpate. So opening snap. So OS is one of the important component of your mitral stenosis. And if they ask you a question like, does OS occur in MR? Is it yes or no? What is your answer? I want few of you to like type and tell. Like they'll ask you OS is like we tell like A2 OS gap is something which we used for like characterization of severity of MS. Okay, A2 OS gap. I'll tell during telling MS like what is the total gap, like A2 OS gap. So we are going to use the opening snap is characteristic. Okay, but if they ask you is it like found even in case of MR, so you have to tell answer is yes. So in case of severe MR, you can find opening snap. But always what is the problem is like they'll ask you one more thing, like with what other sound you are commonly going to mistake with the OS with. So MR OS, okay. Opening snap in case of like what I'm telling is opening snap is characteristic of MS. It is like characteristic, and in case of MR, it is seen in case of severe MR and always confused with S3 of MR. So MR will have S3, so that S3 may be confused for OS. So we don't go in too much detail like how do we differentiate S3, OS and all. It is for postgraduate level. So these are the only 2 questions you are going to answer. So MR can also have opening snap, and it is most commonly confused with S3. Okay, so this is a diastolic event, right? So diastolic event, so S3 can be confused with OS. So next is again murmurs and thrills. You can auscultate, like for example, if there is a grade 4, then you are going to call it as the thrill. You are going to add it in that. So like 1, 2, 3, 4, 5, 6. When you will come to auscultation, we'll discuss them. So with grade 4 murmurs, you are going to like put in Roman numbers. Sorry, in grade 4, you are going to add something called as thrill is present, absent. From there you start. So you are going to palpate for the different areas for different type of thrills. And in case of pericardial rubs, so in case of pericarditis, you can palpate the rub, which is like with each systole and diastole, you can like you'll be able to feel the pericardial rub. But it's very characteristic. You can auscultate it is if you come back early, then in postings you can ask for any PGs there. In cath lab, like if we have any pericarditis case, they will give you a chance to auscultate. So you can classically, it is very like you'll never forget in your life like how a pericardial rub will be. So it's a very characteristic it will be, and you have to auscultate once. If you come here very shortly, then you can auscultate once. Like this is one more area, everybody's favorite area. This is how do you examine for parasternal heave, and they will ask you to demonstrate. We have got grade 1, grade 2 and grade 3. As we previously saw two images, like they are going to put the heel of the hand on the left parasternal area, and then they are going to examine, and in that we have got 1, 2 and 3. They don't expect you like grade 1 in which conditions, grade 2 in which condition, and grade 3 it is for postgraduate levels. So you can just tell in case of right-sided pathological conditions, you like right-sided cardiac involvement, that time you can have a RV enlargement and hypertrophy, like you can have your whatever you tell, congenital heart diseases could be there, or it could be COPD or asthma, it could be there, or restrictive lung disease causing PAH, it could be there. So you can have chronic pulmonary thromboembolism, acute pulmonary thromboembolism, so many things we have. So you can remember like in this way, but nobody will ask you what is grade 1 cause, grade 2 cause and grade 3 cause. Don't read also. Nobody will ask for your level. What are the causes of grade 1 parasternal, grade 2? No, you are not going to cause, like remember the cause by gradings. Okay, it is not necessary for you people. Then first one, what you are going to do is you can just visualize, like for example, if you want to find out the parasternal heave, if this is the precordium, you can just put the pen, okay, like this, and you can be able to see the tip which is auscultated, like it is like with each beat it is like moving like this. So that can be visualized in case of like grade 1. Like if it is not clearly visualized, you can just like this, you can keep a scale or pen or even a thin strip of paper or something like that. You can see the tip will be just auscultating, like moving like this. With each beat it will be moving, so you can see like that. And in case of grade 2, like you are going to put the heel of the hand, you are going to palpate it, you will be able to feel it, but with your pressure you will be able to obliterate the impulse. So if you put a little bit of pressure, that parasternal impulse will go off. Right, you will not be able to feel. That is grade 2. And it is grade 3 is like even if you put some amount of pressure, enough like moderate or severe amount of pressure also, you cannot obliterate that impulse, and you will be able to palpate at the heel of the hand. So if you tell that much, it is more than sufficient. And we have got many gradings, like how we told about parasternal, like hyperdynamic and heaving type of apical impulse. We have like less than 50% of the systole, more than 50% of the systole, etc. Like that we even have here also, like how much it is extending, but it is not required. If it is given in your book also, forget it. Don't read like how much part of systole is in grade 1, grade 2 and grade 3. They would have given, not necessary at all. They will not ask for you, and it is too much into the depth of cardiology. Palpation of the tricuspid area. So here you are going to look for the sounds of right-sided like event, like your pulmonary stenosis or your tricuspid regurgitation or your tricuspid valvular sounds, like others, like your opening snaps are there. So all those you are going to look at the tricuspid area. Not much important in case of palpation per se, not that important. And in case of aortic and pulmonary areas, it is important because in aortic area you will be able to feel many of the sounds, like your secondary to your hypertension, aortic stenosis, aortic regurgitation, pulmonary hypertension, and all those things you are going to look here. But predominantly again, these will be more like theoretically they will ask you so many questions regarding your splitting of heart sounds and all with respect to auscultation of pulmonary areas only. Here they are going to ask you too much, like what are the different type of pulmonary like splits you are going to get and all. But you should remember 2 to 3 causes, like you are having a systemic hypertension, aortic stenosis, you are going to get an aortic regurgitation. You can sometimes feel the impulses or the aortic areas, and in case of pulmonary areas it is due to pulmonary stenosis and pulmonary hypertension. So if you tell this much, it is more than sufficient. And one more thing is, where are you going to put the fingers? They'll ask, like you are going to tell we are going to use the tip of the fingers at the left second intercostal space for auscultation of the pulmonary areas, like for the palpation of the loud P2, you are going to put the tip of the fingers in the left second intercostal space. So as we said, again, palpation of epigastrium, you have to put the thumb like this, and you are going to have 3 like here 1, 2 and 3. So you're going to do it. And other palpation of ectopic areas are your sternal clavicular joint, like suprasternal, sternoclavicular areas, and even you can feel the murmur sometimes even in the axilla. So you can put your hands into the axilla and you can palpate for the MR murmur which is occurring and it is radiating back to the axilla. So MR murmur, how it will be like, for example, if you have mitral regurgitation, if there is anterior mitral leaflet involvement or posterior mitral leaflet pathology. If anterior leaflet is involved, then the radiation of jet of the blood will go to axilla. If posterior mitral leaflet is involved, the jet will come to the base, like near the sternum it comes. So if AML is involved, murmur or thrill can be heard better in axilla. If PML is involved, you can feel it at the base of the heart or over the sternum. So if this much is there, then I think it is more than sufficient. So any doubts here? So if any doubts are there, you can put in the group, like if anything is there.